Good afternoon. My name is Janie Gordon, and I'm with the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center, the Maryland Department of Health and Mental Hygiene, and this month, the Johns Hopkins Center for Public Health Preparedness, I want to welcome everyone to today's presentation, our October Public Health Practice Grand Rounds on Disaster Preparedness, Public Health Infrastructure, and Perspectives on Community Resilience. I have a few announcements before we get started. For people who are watching online, please check out our archived Grand Rounds and other online trainings. Our next Grand Rounds will be November 20th, and we'll have more information available soon. For those watching online, you can email a question for today's presenters by simply clicking on the link, or you can send your email to maphtc@jhsph.edu. And there'll be a slide at the end that has that email address. With that, we're ready for today's presentation, which promises to be outstanding. And it is on disaster preparedness, public health infrastructure, and perspectives on community resilience. I'd like to introduce today's speakers. Daniel Barnett, MD, MPH, is currently on the core faculty of the Office of Public Health Practice and Training at Johns Hopkins Bloomberg School of Public Health, where he is an assistant professor in the Department of Environmental Health Sciences with a joint appointment in the Department of Health Policy and Management. In conjunction with his applied research interests on public health emergency preparedness and response, Dr. Barnett regularly trains public health and other healthcare workers in content that highlights the dual-use applicability of emergency preparedness concepts to daily public health practice activities. Prior to embarking on his academic career at Johns Hopkins, Dr. Barnett worked at the Baltimore City Health Department's Office of Public Health Preparedness and Response, where he conducted preparedness training activities for the department's workers. Dr. Barnett is a graduate of the Johns Hopkins General Preventive Medicine Residency. He received his MPH degree from Johns Hopkins and his MD degree from Ohio State University College of Medicine and Public Health. He graduated from Yale University with a BA in English. Dr. Randolph Rowel, PhD, our second speaker, is an associate professor in Morgan State University's School of Community Health and Policy. At Morgan State University, he is the interim chair of the Behavioral Health Science Department. Dr. Rowel serves as FEMA's private sector representative, a rotational position in which he advises FEMA on individual and community preparedness issues, especially for underserved populations. Dr. Rowel is currently co-investigator with the Johns Hopkins University Bloomberg School of Public Health Preparedness and Emergency Response Research Center, it's a mouthful, on Towards a Community Resilience Index, a project that will develop an index to be used as a predictor or pre-event of peri- and post-event resilience. Dr. Rowel served as an investigator for the Department of Homeland Security-funded National Center for the Study of Preparedness and Catastrophic Event Response. Dr. Rowel and his research team conducted a study which examined the relationship between daily crisis, community stressors, and disaster preparedness. Dr. Rowel also assisted in the development of an online undergraduate disaster awareness course, and in a unique partnership with the Washington Bible College, he co-developed a course entitled The Role of Pastors in Disasters, Training Pastors to be the Agents of Safety. He has been a contributor to the National Dialogue about Social Networks and Resilience. Dr. Rowel received his master's and doctoral degrees from the University of Utah and the University of Maryland College Park, respectively, and his undergraduate degree at Morgan State University. So with that, we're delighted to have our own Dan Barnett, and we're especially pleased to have Dr. Rowel from Morgan State University. So I'm going to turn this over to Dan.
Well, thank you, Janie, and thanks to all the sponsoring institutions today. It's a pleasure to be able to present on work that colleagues and I have been doing over the past 4+ years, going on 5 years now, looking at a particular aspect of community resilience, and that is the willingness of public health and other health infrastructure cohorts to come to work in disasters in the first place. And one of the things that we've found through our research is that members of health responder cohorts are themselves part of the community, and they've experienced many of the same concerns, anxieties, and uncertainties that the rest of the community experiences in terms of their response roles. And so that's an underlying theme, and I know that my colleague, Dr. Rowel, will be expanding on that from the context of communities as well. So the objectives for my portion of the presentation are as follows. I'm going to describe influences of how perceived threat and efficacy shape public health workers and other healthcare workers' willingness to show up to work in disasters. I'm also going to describe some scenario-specific patterns of emergency response willingness. One of the take-home messages from my portion of the talk is that willingness to respond is a scenario-specific phenomenon and is based on a complex interplay between a variety of factors. Finally, it's not enough to diagnose gaps in willingness to respond. It's also important to identify evidence-based approaches to addressing those gaps. And in this project that I'll be discussing, we've piloted a novel experimental curriculum designed to enhance willingness to respond in local health departments, and we've since adapted that for hospitals. So I'll be talking about that as well. I also want to give acknowledgement from the outset to CDC, which has sponsored or funded this project, as well as the other collaborators. We consider them not subjects, but collaborators from health departments across the country who've made this project possible. So by way of background, we face a spectrum of public health emergency threats. And there's a term that we use called the all hazards spectrum or all hazards continuum, which means that in public health we have to be agile and versatile enough to deal with threats ranging from naturally occurring events, such as naturally occurring infectious disease emergencies. Bird flu is just one example. Others on the horizon or on the current radar include Middle East respiratory syndrome, H7N9 infection. So we are constantly on the lookout for naturally occurring infectious diseases. We're also seeing an increased number and frequency and severity of naturally occurring weather events, obviously naturally occurring, but these may also be related to human effects of climate change, of course. And then finally, I'm going to talk about another spectrum of threat which relates to terrorism. And there are a variety of terrorism-related threats, one of which I'll focus on today is a radiological form of terrorism called a dirty bomb, which is basically TNT bundled up with radionuclides to cause more psychological trauma to populations even than physical trauma. This is a very important slide because it highlights what's known as the Public Health Emergency Preparedness System. And this comes from the Institute of Medicine, originally from 2002, and it was refined in 2008. And basically, this diagram highlights the various participants or actors who comprise public health response to disasters. Importantly, at the heart of this diagram is the governmental public health infrastructure. And by governmental public health infrastructure, we're talking about the health department fundamentally as the epicenter of this all. And there's an old expression that all disasters begin locally. So by extension of that concept, really the local health department, at least in the United States, is at the heart of this system. We also have hospitals, communities, Dr. Rowel will address communities, academia, the media, the private sector, and Homeland Security and Public Safety. This is an integrated network of various players who play critical roles in response and preparedness. My colleagues and I at Hopkins have developed a framework based on the catchphrase ready, willing, and able to describe what are the requisite elements of a quality public health emergency response. So I come from a clinical background, and in clinical medicine we have an abundance of very well-tested metrics for quality. What are quality outcomes following an MI, for example? We have very good data on that. In the field of public health emergency preparedness, we are not yet at a point where we have rigorous, metrically driven assessment approaches to understanding what was a quality response. So if you ask people, for example, was the plane that landed in the Hudson River a few years ago a quality example of a quality response? Most people would say yes. But then if you sort of drill down, you sort of realize that it's more the eyeball test that people are using to drive that assessment rather than rigorous metrics. So the three components of this diagram are readiness, willingness, and ability, and I'm going to define each in turn, and I'm going to conclude with ability, which I'll focus on today. So readiness means, do you have the physical infrastructure in place to deal with an event? Do you have, for example, surface streets and highways that you can access reliably in an emergency to get to work? Do you have, at the household level, do you have plans in place, personal and family preparedness plans, so that you can feel safe as a healthcare worker knowing that your family is protected so that you can come to work comfortably? And it also readiness also relates, do you have plans at the institutional level in place? Not plans that are just sitting in some dusty binder, but plans that are exercised and understood by all employees so they know where they fit into the overall scheme. The next portion of this model that I'll talk about is ability. Ability means what you think it does. It means knowledge and skill sets that relate to how response gets operationalized. Most of the trainings, in fact, virtually all trainings to date, internationally and nationally, have focused on ability as their discrete outcome for preparedness. And that there's an assumption behind that's sort of implicit. That assumption is that if you train someone how to look at anthrax under a microscope, they're going to be willing to show up to work to look at anthrax under a microscope. And that is an assumption that's a very dicey one to make, and we have an abundance of data that suggests that it's actually a dangerous assumption to make. Finally, I'll talk about willingness to respond, and that's really the part that's of preparedness that's received historically the least amount of attention. There's a growing body of literature on it that my colleagues and others have begun to develop, but that reflects attitudes that drive someone to come into work in the first place. So our hypothesis is that the size of the overlap of these three Venn diagram circles in the center is proportionate to the probability of a quality response. So the next step in research on public health emergency preparedness is to identify what are the relevant subcomponent metrics that actually are meaningful. And so that's where we are in the field. So this is a sort of a 50,000-foot view, but we need to drill down as next steps in this research domain to really identify the critical elements of quality. You can do all the training in the world on how to use two-way radios, how to recognize signs and symptoms of a particular disease, and so forth. But if you don't have the willingness at baseline to come to work to apply those knowledge and skill sets, all the training in the world is really fruitless. And that's why this is such a critical issue to study, willingness to respond. As I mentioned earlier, one of the take-home findings that we and other researchers have found is that willingness to respond is scenario specific. What do I mean by that? I mean that my willingness to come to work in a weather-related emergency may not be the same as my willingness to come to work in a terrorism-related event. And in fact, my willingness to come to work in a radiological terrorism event may not be the same as my willingness to come to work in a biological terrorism event. So again, there are gradations of willingness to respond, and these are very scenario-specific phenomena. And a whole host of psychological and other factors come into play relating to risk perception. We have used an online survey instrument called the Johns Hopkins Public Health Infrastructure Response Survey Tool, and I believe we may have online some colleagues from health departments that have taken this instrument. This is an online tool that uses a behavioral model to assess willingness to respond in health departments. And it's about a 15 to 20 minute survey. It asks about 4 representative scenarios across the all hazards continuum, including a weather-related event, pandemic flu, inhalational anthrax bioterrorism event, and radiological dirty bomb terrorism event. So the model that we use to underpin this survey is called the Extended Parallel Process Model, and I'm very applied in what I do, and this research is very applied, but it's important to briefly understand how this model applies in practical ways to health department workers' perceptions, because these ultimately are foundational to our understanding of willingness to respond. So here's an animated model or depiction of how the model works. So if I were to try to convince someone, let's say, to make a preparedness kit who didn't have one, and by the way, historically, rates of personal and family preparedness, as Dr. Rowel can attest, are very low nationally and by every poll that's been done virtually. So let's say I were trying to get someone to make a preparedness kit who did not have one. The model says that I need to do 2 things. I need to convince that person that there's a legitimate threat out there that's worth making a kit for in the first place. In other words, threat perception can actually be motivational toward a desired behavioral outcome. So if I'm asking people in Miami to make a snowstorm preparedness kit, that's a non-starter. I have to present a scenario that people perceive as realistic, something that they're susceptible to, and is severe enough to warrant their attention. But that's not the sole part of the model. That's only one step. Next, I have to perceive them, to convince them of the efficacy perception element. And there are 2 components to efficacy perception. One is self-efficacy, which is perception that I'm confident that I can do what's being asked of me in the context of, let's say, making a kit. It's easy to make, it's not that expensive, doesn't take a lot of time to assemble in our example. That's called self-efficacy. The other part of efficacy is called response efficacy. What that means, in short, is that if I make a kit, I feel it will make a difference in actually keeping my family safer. If you can't convince someone of response efficacy, then they're not apt to endorse the desired behavior change. So these are the 2 elements, and this is how it plays out. Let's say, and by the way, I want to preface everything I'm about to say about models with the following expression that was coined by a biostatistician who said that all models are wrong and some are useful. And that is true. There is no such thing as a perfectly descriptive model. But models can be extremely useful in helping us understand behavior and tendencies towards certain behaviors. So having said that, the model predicts that if I can't convince someone of the threat, they will not process the message further, and that will result in message rejection. The model then says, well, let's say I'm able to convince someone of the legitimacy of the kit as the basis for making, legitimacy of the threat as the basis for making a kit. The model says that, okay, I've convinced you of the threat, but if I fail to convince you of the efficacy, then you will engage in what's called fear control. You will engage in denial or avoidance responses to manage your fear that I've now instilled in you, but will not actually take proactive behaviors to make a kit. So that's a very bad place to be psychologically. If you're frightened without efficacy, people engage in denial or avoidance responses and ultimately will not do the desired behavior. The model predicts, though, that if I can convince you of the threat and the efficacy component, then you are apt to engage in something that's a positively adaptive response called danger control, where you're actually managing the hazard rather than your fear of the hazard. And in this case, making a kit as desired, and ultimately, of course, accepting the message. So perceived threat and efficacy are the 2 elements that are requisite elements according to this model. I mentioned this model because, as I alluded to a moment ago, we've used this model in this study I'm going to talk about to underpin all of our work, to underpin the survey assessments of willingness to respond, and to underpin the intervention to address gaps in willingness to respond. Very briefly, in this online survey instrument, we ask on a Likert scale about people's agreements with their perceptions of threat and efficacy for each of those 4 scenarios that I mentioned earlier. You can divide any group of healthcare workers into 4, or anyone actually, into 4 categories based on this model. So the first group, and I'll be colloquial on purpose here, the first group is the I'm not worried about it and I don't think I could handle it anyway group. The second group is the I'm not worried about it, but if it happened, I think I could handle it. The third group is I am very worried about it and I don't think I could handle it. That's a bad place to be psychologically, as you'll see when it comes to willingness to respond. According to the model, if you had to pick one group or one profile of a public health or other worker who's most apt to be willing to respond, it's this last bullet, what we call the concerned and confident worker. Concern is the same as threat, confidence is the same as efficacy. So a worker who has enough concern to motivate toward the desired behavior, in this case showing up to work, and efficacy that if he or she does show up to work, he or she knows what to do once there. Okay? So that's the sort of gold standard, that last bullet. So we've launched a variety of projects to date looking at different cohorts. I'm only going to highlight 2 very briefly in the time that we have. But we've looked at willingness to respond among hospital workers in a pilot study done at Johns Hopkins Hospital in 2009. And we've done a longitudinal study of willingness to respond among local health department workers. It's the largest of its kind, to our knowledge, to date among the local public health workforce. We've looked at over 70 health departments in 9 U.S. states over a course of 5 years, approximately, in this study. And our total N for this study is approximately 3,000 local public health workers. So I've already highlighted the importance of the concerned and confident profile. One of the other things that I'm going to point to is that, unlike what the model would predict, and again, all models are wrong and some are useful, actually, efficacy weighs more than threat. So the model would predict that if I can't convince you of the threat, all is lost, right? You're not going to process the message any further. But what we've actually found is that even if I can't convince you of the threat, as long as I can convince you of the efficacy piece, you are much farther along your way to being willing to respond than if you're in the reference group. And our reference group is the I'm not worried about it and I don't think I could handle it anyway baseline reference group. Okay. And one other point I want to highlight. We've now surveyed, in addition to the cohorts I'm going to talk about today, medical reserve corps volunteers, EMS personnel, and we've looked at over 5,000 different employees across different sectors of the public health preparedness system. And we've found that without exception, literally without exception, the lowest rate of willingness to respond has been to the radiological dirty bomb scenario. So radiological threats are particularly high risk perception threats. There's a lot of excellent research by people like Paul Slovich at University of Oregon and others who have looked at how people perceive risk. And radiation is a particularly high risk perception category. Very briefly, I'm going to highlight some key findings from the 2 cohorts I mentioned a moment ago. Hospital workers. We surveyed employees at Johns Hopkins Hospital. The response rate was 18.4%. We then did a non-response analysis and found that those who responded were not demographically different from those who did. So I'm comfortable to report these findings accordingly. And as you can see, Hopkins Hospital is a very large hospital. A couple of trends that you'll see repeated elsewhere in these findings. Willingness to respond is greater when required to come to work than if your employer says, we'd like you to come to work, but we're not going to force you to come to work. Now, in actuality, I have colleagues who are public health lawyers, and I've asked them, can you physically impel someone to get out of bed and drag them into the office? No, you can't. But there are other ways of requiring someone to come to work. As one of the Maryland health officers who I know once said to me, I can't force you to come to work, but we can revisit your employment status afterwards. So there's different ways of getting people to adhere to workforce response expectations. Also, you'll notice if you cut this table in half, you'll see lower rates of willingness for both required and if asked for the radiological scenario than for the pandemic flu scenario. So again, high risk perception attached to the radiological scenario. The take-home message from this slide, which has been repeated in other studies, is that in research on willingness to respond, it's been found that physicians are generally more willing than nurses to come to work in disasters. And more research needs to be done as to why this is the case, but it has significant implications for surge capacity. By far the largest cohort of health providers in this country are nurses. And so any gaps in willingness to respond among nurses, and as you can see, for example, willingness to respond to a pandemic flu event among nurses, regardless of severity, 50%. That's a huge gap in surge capacity, the ability of hospitals and healthcare systems to ramp up in the face of demand. That's a huge gap that has implications for service provision in a pandemic. And that's just one example. And other researchers have found similar observations. There are a lot of odds ratios on this table, and I'm not going to spend a long time on it, but I do want to highlight that this goes back to the point I made earlier, that all is not lost if you can't convince your public health workforce, or health, in this case, hospital workforce audience, of the threat, as long as you can convince them of the efficacy. Those who have a high sense of efficacy are anywhere between, or approximately on this slide, 13 times more willing to respond than the baseline reference group. Notice those odds ratios in the second column are actually higher than the odds ratios for what I said were the gold standard according to the model. So that again highlights that efficacy weighs more than threat. So that means that if you're training to boost willingness, even if you can't convince people of the threat, as long as you can convince them of the efficacy, you're well on your way to building willingness to respond. And I've summarized these points on this slide. So again, this all points toward the need for efficacy-focused training to boost willingness to respond. And that's what I'm going to briefly talk about in the subsequent slides. So as part of our study with local health departments, we developed a novel curricular intervention called the Public Health Infrastructure Training, again, based on this extended parallel process model, to help bolster willingness to respond. So this is a unique training in that most trainings focus on knowledge and skills, as I mentioned in that ready, willing, and able slide, but this training actually focuses on attitudes as a discrete outcome. And it's a train-the-trainer style of training, 7 hours of learning time over a 6-month period. It combines blended learning approaches, face-to-face, we don't really call it lecture so much, facilitated discussion, even though we call it lecture and discussion. Online learning activities relating to, for example, risk communication and other skill sets that we've found to be related to willingness to respond. Independent activities including mapping out multiple routes to work and making a preparedness kit. We also do, at the end, tabletop, which is a discussion-based exercise. And I should mention that this training is tailored to address gaps identified in the baseline administration of that survey that I mentioned a moment ago. So it's explicitly using data to address gaps in willingness. So this is just a summary of the table of contents. Again, health departments have given us good feedback on this as an overall approach toward bolstering willingness in a way that respects their time. Health departments are busy places, and I used to work in one, so I can attest to that. And so we've tried to make this something that uses adult learning theory and something that is manageable in terms of the multitasking roles that health officers and their employees have to conduct on a daily basis. And so we try to make this very user-friendly, and people have actually found it engaging based on the focus groups we've done on it. So does this curriculum actually work? So have we made good use of these 7 hours of learning time? And that's kind of the ultimate question that we wanted to ask. The way to read each of the cells on this table, and I'm going to use my mouse to highlight, so basically we had a control group of health departments which did not get this curriculum that I talked about, and an intervention group. The first percentage in each respective cell is at baseline. The second percentage is at 1 month post-curriculum, and we resurveyed both control and interventions at the same time. This is like a randomized control trial. And the third number, sorry, I'm not pointing to it exactly, but the third number in each cell on the far right is at 6 months post-curriculum. So what you can see based on these findings are a couple of trends. This curriculum has a particularly strong impact on bolstering willingness to respond toward scenarios that are associated with perception of fear or high levels of fear or dread. And there's a researcher named Peter Sandman who's done work on risk communication, who's found that this formula applies called perceived risk equals the actual hazard plus this sense of outrage or dread. And dreadful scenarios include things like terrorism scenarios. So if you actually look at the percentage changes, this is willingness to respond regardless of severity. We saw a 16% increase at 1 month post-intervention for the dirty bomb, and that held relatively at 6 months post, so a net 14% increase. And smaller but notable increases for anthrax bioterrorism. Now you may say, well, 16% increase, that's not a whole lot. These are all hands-on-deck scenarios, so every single percentage increase actually makes a difference. This curriculum, again, does not apply as directly toward scenarios we've found that are familiar to people, so weather-related and pandemic flu. But again, some of the biggest surge capacity challenges are toward the unexpected and exotic, and that's part of the all hazards continuum that we have to be mindful of. This is self-efficacy. Self-efficacy, I should mention, is the leading predictor of willingness to respond based on our research. Another question you may have been asking, and I'm happy to address later, is, well, does someone's response to a survey reflect their real-world behavior? It's a great question. We don't know exactly, but we do know from research by Alfred Bandura from Stanford that what people say about their own self-efficacy is actually predictive of real-world behavior based on decades of psychology research that he's conducted. And so standing on his shoulders, we got a little bit lucky with our findings on this study in the sense that we actually identified self-efficacy as a leading modifier. By the way, for this curriculum, we always focused on the scenario that had the lowest baseline rate of willingness. So we always focused on the dirty bomb scenario. So we saw about a 30% increase in willingness to respond, 29% to be exact, at 1 month, and only dropped by 4% at 6 months for the intervention group for the dirty bomb scenario. And similar but a little bit more muted increases for the anthrax scenario. Response efficacy, 12% increase for the radiological scenario, terrorism scenario, dropped by 8% at 6 months. Less marked changes for the anthrax bioterrorism scenario. And again, we're not seeing much in the intervention arm for the weather-related and pandemic flu. I should mention that for all of these contexts, the control group did nothing, which is always reassuring to see in a randomized controlled trial. So from our focus groups, which we conducted among intervention health departments, we found that participants reported increased understanding of the importance of their roles, i.e. response efficacy actually, and in the potential impacts that their agency has on the community if they choose not to respond. So one of our activities is to ask people to identify what are the ripple effects if you choose to show up to work on yourself, your family, your agency, and your community versus if you choose not to show up to work. And a lot of employees found that to be very enlightening because they didn't really think of themselves as critical to the overall agency response. In other words, response efficacy, as I mentioned. Being confident in the safety of one's family is a critically important operational, practical finding from our study. What does that mean in concrete terms? If you are a health department and you're responding to a pandemic event, employees are much more apt to be willing to respond if you are giving them and their families first dibs at antivirals and vaccines. And other researchers have found this too. So if you're asking them to come to work on the front lines, there is this perceived, at least, and we're actually doing more research, which is very exciting, on this issue, but the sense that there's an obligation from the agency to the employee to provide them and their families with personal protective measures. And that concludes my portion of the presentation. I'll be happy to answer additional questions during the panel discussion, and I'll turn it over to my colleague, Dr. Rowel. Thank you.
Okay. View and show. Let's see here. Yeah, here it is.
Thank you, Dan. Again, thank you for inviting me to be a part of this discussion, and it's very interesting to see just how far Dan and his colleagues have come with his research. We've worked together for some time. Years ago, we did a symposium at Morgan in collaboration with John Hopkins on the Why Culture Matters, Public Health Preparedness Symposium. And I've had an opportunity to continue that relationship with Dan and Jonathan Links and others, and it is really enlightening me. But to see this, it's the most exciting aspect of this is that public health theory-driven approaches is becoming more and more, not only in public health arena and CDC, but I'm also seeing it on the DHS side. So one of the things in terms of my research and what I have deeply been involved with over the years is looking at vulnerable populations and the types of issues and things that mobilize them to get involved. First, to understand low-income populations and some of the barriers and some of their perceptions about various issues. So some of my research and looking at exploring ways to look at unique ways of engaging the community. For example, we've used art engagement as a way to talk and engage communities around disaster-related issues. We've also were involved with the Center of Excellence for DHS, is where I did some research, again, working in collaboration with John Hopkins. And one of the unique opportunities I had recently was to work at, not work, but maybe to begin to look at some work at FEMA as a private sector representative. Now, so today what I'll talk about briefly is just that experience. Keep in mind that I am in public health like many of you, and a lot of my work has been in DHS, which is like a fish out of water sometimes. So it's a good, it's been a rewarding experience because I could see the role that we really can play in helping DHS to begin to look more towards behavior change theories to drive the types of outcomes they're looking for in terms of national preparedness. So I'll talk a little bit about that. I'll share some information about a recent national state of preparedness study done by FEMA, and also begin to talk about community resilience and discuss its practice implications. And then an ecological framework for community resilience is where I'd like to end. So as a FEMA private sector representative, what does that mean? Well, first, they've only done this for about 6 years, but they invite usually the private sector, someone from businesses, to actually work in headquarters for a 90-day rotation to get a really in-depth understanding of how FEMA works. And so for most of the summer, I found myself in downtown Washington, D.C., where a badge around your neck rules. I mean, you can't get in a building without having a badge around your neck. So it's a very interesting culture, I might add, in terms of security and all those issues. The private sector representative gives FEMA an opportunity to share with persons like myself the opportunity to see how their daily operation looks at headquarters. It also gives them an opportunity for a person like myself to share my research expertise, and this was the first time they've actually invited a researcher to be a part of this private sector representative position. And in that capacity, I work closely with their social media effort. I work closely with looking at campus resilience, and what they're about to roll out is a campus cert on a campus-ready website. I had input into reviewing all the documents they had and gave them some insight in terms of what's important on campus communities and what mobilizes students and what mobilizes faculty to get involved and to bring home the reality that tenure and promotion somewhere in the mix of all this has to be addressed if you want to mobilize faculty and as well as others. Exploring the individual community Preparedness Division, they had quite a bit of data that they have not figured out, unlike CDC, a way to share that data so that other researchers can do secondary analysis. So I had an opportunity to have input into that. And then there's the Higher Education Academic Advisory Council. This was an advisory council that has been meeting with presidents and looking at campus resilience across the nation. So this unique opportunity really brought me closer to understanding what goes on inside a FEMA. And what's interesting, I know that most of them are still working, but what's interesting in terms of partnering, now they have, I worked in the Office of Private Sector Relationships, and what's most interesting is they do a tremendous amount of work to build relationships with academia, with businesses, with community groups, and all it takes is a disaster and they're gone. They actually disappear and go to do the work of response and recovery. So that's a unique type of relationship that we need to understand in FEMA, that is when something happens, the persons that we're working with, they don't just stay there and have another crew that goes out and do the work. They're the ones that actually respond. So again, understanding the culture of FEMA is just as important as we look at resilience, because we have to understand the culture of various groups and community groups that we work with. So let me just start off by sharing with you some of the information from the national study. And that information simply states that nearly half were aware of local hazards. That was up only 14%. We're only talking about 30-some% on average. Those who believed they were at risk took actions. That was another key finding. And all of these findings in many ways fit very strategically and accurately with many of the public health theories that we study, that people cue to action and all those things that we look at, various constructs of different theories, actually have a place in disaster preparedness. There was also a decline in preparedness training. This was a study that was done from, I think, looking at in 2012. They found that in terms of the remember, these are 4 actions that FEMA requests many of us to take, and that was to make a plan, and they found there was a slight decline in having a household plan. Build a kit. Those with update supplies declined as well. Get involved. No change in those that support emergency responder organizations. 22% or to help in disasters. So the engagement of groups to get involved is something to think about. And I think that as I listen to Dan's study, I think there's definitely a need to look at some of those similar types of constructs among individuals. Now, I got excited again when I saw this study, because they're using they're using the theory of change as one of the constructs for their national survey. So they're looking at pre-contemplation and found that 21% had no intention of doing anything towards preparedness. Contemplation, those in that stage, 19% were giving it some thought, and 9% had started taking some actions, but only 15% were actually doing it, and then 34% was maintaining. So what's, again, important about the use of these theories is because they can result in evidence-based models such as the one that Dan and his colleagues have created. And that the beauty of this is that for every last one of these types of stages of change, there is an opportunity to design specific interventions to move one along the change continuum. Now, community resilience, since we're on that topic, it has probably been used, it's used quite a bit throughout the disaster emergency management field. However, I tend to have, as a researcher, yes, I'm very in tune with the terminology and working here with Jonathan Links and others, even looking at the metrics around creating a disaster resilience index. But in practice, when I met with this summer with some of the practitioners at the Emergency Management Institute, resilience takes on a whole different perspective for those who are working in the emergency management field. They don't quite necessarily understand. They do the reports and they report the information that's required, but in reality, I don't think that they thoroughly understand the potential and that this approach has. Now, resilient communities can withstand hazards, continue to operate under stress, and that's what we're looking for. How can communities bounce back to some level of being normal again after a disaster? One of the studies that I was involved with, a national study by the National Academy of Science, clearly indicated from our meeting with over 200 emergency management practitioners or planners, is that community resilience is not just about disasters. That was a real big eye-opener for me, because I realized, and many of us have already realized, that the strength of a community rests in its ability to deal with crisis regardless of what type of crisis they are. So if we work more closely with communities to help them become more resilient in general, then that means that social capital and some of these other constructs of what we're looking at in terms of resilience can be improved. So the term social resilience, social justice, all these things have been affiliated with, and I'll share with you a diagram by Norris and her colleagues. But the committee also found that the private-public collaboration is crucial. And when we say private, we're not just thinking about the business sector, but also community sector, academic sector are very important in collaborating to build these networks of trust that are vital to any type of collaboration. Now, one unique, something that most of you in public health can attest to, and that is you're probably being trained in many ways to do partnering and collaboration. These are things that for public health we've done for many years. However, this is quite different in a structure where you think about the incident command that system. It's very hierarchical, and that's what you need perhaps during a response of a disaster. But when you're trying to build partnerships, you can't tell people what to do. It's a totally different type of leadership in which many are not trained to do. So public health, in many ways, your training and those of you involved with public health are quite familiar with the need and the process for how to build, maintain, and sustain collaborations. So resilience is built on the ability to build those relationships. Again, I mentioned the just adaptive capacities that Fran Norris and others have looked at, and they're looking at the whole issue of resilience. If you notice, the information and communication, these are all information, communication, community capacity, economic development, as well as social capital. These things are all critical to being able to build a resilient community. Now, if one can do that, it's the likelihood, at least it's hypothesized, the likelihood that a community can respond to various crises is that much greater, which we've seen in many instances. So as some of you may be aware of, and much of what is a driving force, I'm sure, behind Dan's work, and realizing that the whole community approach, now FEMA has taken a different approach over the last years, primarily because they realize that there's no government agency that's large enough to deal with catastrophes and disasters, that whether they're purposely asked to be involved, people will just simply do what they have to do to survive. It's interesting, in the Katrina study, they found that of the persons who were evacuated, roughly 42% were rescued by National Guard, and another 40-some% were rescued by friends and family. So it's a natural thing that when we're in need, if I'm going to evacuate a city, before I go to a shelter or a hotel, I'm calling up my family. So it's important to understand that these natural and social networks that we have are really the most important aspect of what we're doing. So again, the whole community engage in all aspects of the community, strengthening the assets, institutions, and social processes that work well in the community. Again, this whole approach is beginning to look more at the assets, the strengths of the community and what they're capable of doing. One of the underlying reasons why we need to really be about the business of preparedness is because you and I are the first responders until the help arrives. Now, what that means is, yes, my friend and colleague over here, the doctor, the MD, if something should happen to me right now, I'll have a greater likelihood of survival with him being here or with some of you who may have similar backgrounds. However, in reality, there are certain things that only a certain amount of things that Dan can do. If my sugar dropped very low, for example, emergency managers come in with their gear and they can actually get my sugar back where it needs to be. So we're limited. Even when we have the expertise, we're limited. But in reality, you are the first responder until the help arrives. So that's the reason why preparedness is so critical and crucial to our nation. So talking about communities, and Dan talked about the public health community, and I think that we need to really look at, when we understand that community is about membership and sense of identity, and some of the things and characteristics of community, there is a community right here in this room, in this school, a community of students, a community of faculty, a community of staff that make up a community. So I think we need to look at communities in a more broader perspective, not just physical places where people live, but understand that regardless of what the community is, that these characteristics are critical if you want to work with that community. Therefore, we look at the definition of community, but we understand that as public health practitioners, we have to be able to engage with all types of communities. And the type of work that Dan and his colleagues are doing in the public health arena is the same kind of impetus and challenge we have with working with at the very community-based level. Unfortunately, the resources are far and few to conduct this kind of work. Again, the issue of policy. So at the base, at the real foundation of when we talk about community is the community engagement process. How do we get people involved? How do we engage communities where the likelihood of a disaster is very low, although the consequence could be very high? How do you get people involved with getting ready for a disaster, getting ready for something that hasn't happened for 20 years or no one has heard in their family about any type of event happening? So again, talking about perceived threat, again, going back to the construct that Dan is using, these are the issues that have a lot to do with how we behave. So if there hasn't been anything, if one's family has not reinforced the need to be prepared because they have not seen it, it's quite different than an environment where people see disasters quite frequently. I would guess that the national study that was conducted, if they look more closely in the areas where disasters have hit, they would find a difference, some variance in the types of communities that are affected by disasters as compared to those who are less affected. So when we begin to look at how is resilience and how is it linked to community engagement, then we really understand that to create community resilience or the continued ability of a person, group, or systems to function, that is absolutely necessary. The first step is relationships. That you can't really find a very good way to work with groups if you don't have relationships. I remember hearing two emergency managers talk about, they mentioned that they have these memorandums of understanding between counties and cities in case there is an emergency, but when the emergency actually came, something that was not in the memorandum of understanding, one of these colleagues picked up the phone and said, "I need." And because they had a relationship, the person was willing to do things that were beyond the scope of the memorandum of understanding. That's all predicated on the types of relationships that we build prior to working with communities. And these are basic principles of public health. This is meeting the community where they are. These are the kind of concepts that we have been practicing for years. So again, the cooperation between the private, public, academic, and community sector. And I'd like to, although private sector oftentimes includes the academic, I think that we need to, one of my recommendations to FEMA was that we really need to understand the contributions that you, the researchers, can bring to these enhancing preparedness. We are the ones that have theories and constructs and intervention strategies, and our role perhaps has been underutilized. In a recent work I did in Haiti years ago after the earthquake, what we found, public health practitioners like ourselves are not necessarily needed during the response period. But during recovery, when everyone is gone, who's going to work with the community in terms of bringing it back together and facilitating and renewing those relationships? I think public health has the ability to do that. So again, resilience and the types of resilience. So when you start to break it down, look at all the different types of resilience, social resilience, which deals with educational equity and age and transportation, and economic resilience, which deals with housing, capital, income, equality, institutional resilience, mitigation, previous disaster experience, infrastructure resilience, housing type, community capital, social capital, civic engagement, etc. So when you begin to look at these elements, wouldn't one assume that if any community could build its capacity in any one of these areas, that there would be a much greater likelihood that people are talking with each other, engaging with each other. One of the biggest problems we face today is that civic engagement, social capital, is at an all-time low, where and oftentimes people are not that engaged with what's going on in the community. People know that Madonna texts in a movie, but they don't necessarily know who's the chair of the school board. So again, it's a whole issue of how to make information that's locally relevant to our needs. And having a strong communities is very critical to that. So again, this study that from National Academy of Science, what we learned was disaster resilience. It's not just community resilience. It's not just about disasters. That if you can increase the capacity of a community to solve its own problems and work more closely together, then you will have a community that, if a disaster comes, they will have the infrastructure and mechanisms in place to do better. So what has my journey over the years led me to at this point of my professional career and my research? I've done a number of studies, and had some experiences and worked with a lot of researchers in practice. Most of my efforts, I might add, even though I've done some work with CDC, has been in Department of Homeland Security, which has been, again, very enlightening because they don't necessarily have the perspective and the insight of public health practitioners, because preparedness is prevention. And that's sometimes we get the terminology, we don't realize that the same principles, the same theories that we can apply can very easily be used in this field. And incidentally, the study that I shared some of the findings, that national study just started using some constructs, behavior constructs of a health relief model and trans-theoretical change of stage models in their recent study. So there's hope. Community resilience practice. In summary, I would say that we operate within a broader we need to operate within a broader definition of community. We need to understand that when we think community, we're not just talking about places where people live. The same principles that apply to those communities apply to us. So if I'm talking about community engagement at the Morgan State School of Community Health and Policy, but when I look within our own community of faculty and students that we don't practice the principles that are necessary for building strong, resilient communities in our own location, how can I go out and really advise others on how to do that if I'm not practicing what I preach? So understanding, another issue I think would be helpful is to understand community engagement principles can be applied to any type of community. There are a number, I know NIH has some principles that deal with understanding that community has, how you approach community, and that despite our expertise as researchers, that we have to recognize that communities have, regardless of what type of community, they have their expertise in their own right. And we have to respect that as we work with them if we attempt to be partners in solving some of these problems. We need to create resilient communities because it increases the likelihood of having disaster communities. And lastly, community resilience starts where you live, work, and play. So the ecological framework for community resilience practice, I've begun to starting to look at my research and starting to realize that in many of our cities, the reason why, in some communities, the reason why, again, they are not involved because it's not a high priority. They have not seen a disaster of some sort lately. So I'm beginning to form and working with partners to look at disaster along a continuum. Now, there is a continuum of disaster that starts, I feel starts with daily crisis. And in the study that we did recently, we did look at the relationship between daily crisis, unemployment, son in jail, no transportation, all these things that might be weigh heavily on a person's mind and heart that would make preparedness not interesting. I'm sure we've heard that in public health. This is why we're challenged not just in preparedness behavior, but also with looking at how we can prevent various diseases from being more problematic. So again, this approach that looks at daily crisis, emergencies, maybe as defined by 911 calls. In West Baltimore, for example, we did an analysis of 911 data and discovered that the #1 reason for people calling 911 was stroke related. So my approach in working with the community is to perhaps organize the community around strokes and then bring in the other additional information that they need to know around disasters. And what's quite interesting is along this perspective is that Citizens Emergency Response Team is a training that FEMA has offered, and it's been many people have completed that training. In fact, 15 of our graduate students recently completed last spring, including myself. And what I discovered was that, wow, all of these things that they're teaching us are just as applicable for daily types of crisis as it is for a disaster. But yet, FEMA is promoting it more or less as something that you will need in the face of a major disaster. So you have daily crises, emergencies, such as when you call 911, and you also have disasters, such as the many hurricanes. But then you have catastrophic events that really cripple the infrastructure completely such that people can do very little. So these are different varying levels of disasters that require different types of intervention. Again, going along with similar to what you said, Dan, is that we need to develop strategies that meet the people where they are and focus on their needs. So that concludes my presentation about resilience, and also, again, what I didn't mention was some of the tools and things we've developed around capacity building, such as the role of pastors in disasters is a culturally appropriate curricula for faith-based leaders because it has principles of theological principles along with emergency management principles. Again, it was built on the assumption that faith-based leaders are trained to be crisis managers. That's what they do. So we don't want to assume that they don't know anything about crisis. We want to add to their knowledge base in terms of disasters. So those are just examples of how some products and can be developed. But again, moving towards evidence-based is where we need to really focus our attention to utilize these theories that we have and constructs that we have in public health in particular to advance the preparedness of this nation. Thank you.
I'd like to thank both of our speakers. And I'd like to remind people who are watching online that they can send in questions by just following the link online, or you can email maphtc@jhsph.edu. And I'd also like to ask people in the live audience, if you have a question, if you wait till a microphone is brought to you so that the people online can hear. And I have one question to start with online that is for you, Dan. Your presentation suggests that the psychology of the perceived sympathy for the victims might also play a role in whether or not an individual will respond. For example, willingness to help might be hinged to the willingness to participate in the response effort. What is your opinion?
I think that's a valid hypothesis, something that we've certainly gleaned from focus groups and after action assessments. There were a few communities in our study who, for example, which were inundated by floods, and we did get that feedback. On the other hand, we sometimes got counterintuitive feedback. And again, these were sporadic enough that I can't call them trends, but for example, in one of the focus groups, Hurricane Andrew was discussed. And one of the interesting comments there was, well, I lived through Hurricane Andrew. Don't expect me to show up in another Hurricane Andrew. So sometimes prior experience with an event may actually have the opposite of what one might intuitively think in terms of effect on one's willingness to come to work.
Okay, any questions from the audience? Okay, well, I actually have a question. When I was listening to your presentation, Dan, this one is for you, and you talked about threat and also about efficacy. I wonder if another area, and you touched on this a little, is sort of the domain of responsibility, particularly in light of new hazards, whereas public health workers have traditionally known they're responsible maybe in a pandemic or a hurricane, but these new kinds of events they might perceive as not falling in their responsibility. And is that something actually both of you have looked at?
Well, I think it's a very important point. There have been some demographic assessments of the public health workforce, and if you look at the median age, for example, of public health workers, it's edging toward retirement age, which by direct implication means that many of them began their public health careers well before 9/11 and well before a lot of these new expectations of public health emerged toward disaster response. So there's a bit of a, I didn't sign up for this kind of concept that perfuses some aspects of health departments. On the other hand, on the bright side, there's been tremendous growth in preparedness, awareness, knowledge, and skill sets over the last actually 13 plus years, or approximately 13 years post 9/11. But I would say that there's still a ways to go. In public health departments, there is a culture change that needs to occur nationally. It's a gradual process. We haven't fully arrived at it yet in terms of thinking of oneself as a 24/7 potential responder. And I think that that's one of the exciting but also challenging aspects of the field.
Yeah. And Dr. Rowel, would you like to add to that?
Yeah, I would just add to, again, the whole notion of looking at type of hazard was not, in past years, often distinguished in research. It just was hazard. And so the fact that we realize that behavior is oftentimes determined by the type of hazard and experiences one may or may not have with that hazard. So it is very critical to look at the type of hazards we have.
And I wonder, as a follow-up to that, the difference that we saw in the study between doctors and nurses, if what you think about that, if that could partially be due to sort of role identity or responsibility, or your thoughts?
It's a great question. It's actually a research area that's worthy of study on its own because we have some hypotheses along those lines, but they need to be sort of driven by evidence. One potential aspect, as you pointed out, is, and we hypothesize hypothesized may be related to role identity. Nurses, for whatever reason, feeling more peripheral to response, even though that's not the case in reality, but perception equals people's reality. So feeling more peripheral than physicians do to response. We've seen time and again when there have been mandatory vaccination campaigns, nursing unions have frequently sued for forced protocols like that. And so I think this is a salient research question because without nurses, anyone who's worked in a hospital knows that hospitals don't function without nurses, and given just the sheer magnitude of the nursing workforce compared to physicians, it is a huge surge capacity concern if we have even 25% of nurses unwilling to come to work. And we're finding data, at least in our pilot study at Hopkins, is up to 50% of nurses in certain contexts are unwilling to come to work. So not a specific answer yet, but worthy of further inquiry for sure.
I think one possibility and something worth is the gender issue. And female nurses are primarily consisting of the females, and they have family responsibilities oftentimes that are much closer to the family in terms of functioning than perhaps the husbands in some instances. So I would think that might be a factor as well.
So we might be in trouble as now medical school classes are 50% or more female. We'll have to see what happens. Any questions from the live audience now? Okay, I have another one that came in online. Governmental employees may have different personality traits that make them more risk averse. How does this change what a public health agency training might look like?
These are all excellent questions. I don't mean to sound like a broken record. They're great questions. It is true that there are different personality types that go into different aspects of work life. Let me give you a practical example. In the hospital setting, the only group that had 100% willingness to respond was the surgeons. Now, in the first day of medical school, or roughly at that point, they told us you can probably predict who's going to go into what specialty based on personality type. Having said that, we've also surveyed EMS workers who are very adrenaline driven, and about 52% of them responded that they would be unwilling to come to work if there was a potential for disease transmission during a pandemic event to their family members. So again, personality type doesn't necessarily comport neatly with one's willingness in different contexts.
Do you have anything to add?
One thing I would, as I think about particularly emergency managers and adrenaline driven, there's, emergency management or agencies have this, are being, at least the funding source wants them to work along the lines of resilience and building these whole communities. That's not usually a part of their culture. Again, it's adrenaline driven, so they like to save that life. And truthfully, the whole community approach type work is really about relationship development. It's not anything that you see overnight. It's what you see over a long period of time where you see the benefits, which is quite different culturally for that group than perhaps us in public health.
Okay. I have a question in the live audience.
Thank you, Dr. Barnett and Dr. Rowel. I had the pleasure of working with Dr. Rowel a little bit in the CERT training for the Morgan State team. Building off the question that was just asked, that group of students at Morgan State is also a unique group. They're motivated, much like I'm sure everybody here today. And as an emergency responder, it's not just adrenaline. This is a group of people who were excited about preparing their communities, about being involved. But I sometimes ask myself, how do you build resilience, not just amongst those community members that happen to already have this tendency to seek out problem-solving methods? How do you go into these communities with people living, day to day, not necessarily in a habit of future planning, of assessing risk and mitigating these hazards? How do you engage those citizens in this process?
Well, that's an excellent question. I would say, surprisingly, the students that participated in the CERT training, many of them did it for resume enhancement purposes, I might add. And that's okay. I mean, I think the question becomes when we look at the number of people who've been trained in CERT, and it's not like the local governments have the resources to really follow up and look at how we can do the next thing. What the plan I have is we're about to embark on another training to train more undergraduate students. I'm working with a community partner, and we've established in West Baltimore a neighborhood resilience center. So my question becomes, what do CERT trained persons do when there is no disaster? And I think that we need that there will be an excellent resource to work with communities and organize, not necessarily around the big one or around the hurricane, but around those daily crises, and create a space. That's what we're doing at the Neighborhood Resilience Center, is creating a space where we can provide information, knowledge, and training along the continuum. So it's not just strictly disasters or catastrophes. So that's how I plan to use these students in this coming year.
Okay, we have another question in the live audience.
Yeah, I was just curious, with the education and increase in willingness to respond, particularly with dirty bombs, like, was that mostly an increase in education and knowledge that you think accounted for the improved willingness, or do you think there was something else?
It's an interesting aspect. I think it was a combination. I think nationally, even internationally, there's evidence that suggests that knowledge among the general public about radiological threats is close to nil. And there have even been studies among health physicists which have just shown surprising amount of affective fear versus what they cognitively know. So I think that the increase in knowledge did play a role. Having said that, the efficacy piece also played a critical role, because workers who came to understand the importance of their individual role, in other words, response efficacy in the context of the agency response, and who came to have a better understanding of the skills that they would apply and that they knew how to apply them, that coupled with the sort of increase from zero knowledge to some knowledge seemed to be the interplay that brought it about. And that's what we gleaned from focus groups as well.
Okay, I have another online question. How often do citizens need to practice preparedness-related activities in order to be prepared? How often do people doing it as part of their jobs, like public health workers? Very practical question.
Are you ready for the unexpected? What does it take to be ready for the unexpected? And I think, I always believe that you plan as best you can, but part of emergency response in particular, there is what we call innovation, or some certain things evolve out of the situation. Emergencies, for example, we can have a plan for evacuation to go out these side doors and look at the exit signs, and we all know that in this room. However, what if those doors are blocked? What if, how do we get out of here? And that's going to take the collective will, the collective thinking of the people in this room to look at how we can bring our thinking together to get us out of this crisis situation. So I don't know if there is a number, but I think it raises the question of what does it take to sustain this preparedness behavior. And again, I point to public health. There's a elaboration likelihood model for persuasion, which really looks at the fact that that persons who get more information and understand why they do what they do are likely to sustain the behavior, as opposed to those who are drawn to get involved by one event or some cue to action. So we really need to look at those more in-depth discussions about what it is we do so that it becomes a part of our culture.
Okay, I have one more online and then I'll go to the live audience. There's not much research on race and willingness to work during influenza pandemics. Have you examined this aspect?
Short answer is we have not, and it's something we would love to do. We've looked at virtually every other demographic aspect in terms of length of employment, type of employment, gender, age, but racial perspectives on that are very much important front burner issues to look at. There have been some good studies looking at cultural and ethnicity related dimensions of personal preparedness, but we need to get to that same level with regard to willingness.
And I would only add that, again, research is, I mean, when I think about who's funding research, and Dan and others have been, and myself to some degree, have been fortunate to get resources to do research, but for the most part, it has declined, I would say. It is less dollars available for us to explore these kind of questions that you're answering. And to me, that's at a time when we're having more disasters, more intense disasters, this is a time when we need to understand what works and what doesn't work.
There's a quick follow-up question from the same person saying there's conflicting evidence on age and willingness, and asking about your experience with that.
Well, we actually, so to our surprise, did not find any statistically significant differences by age in health departments that we studied. And we actually didn't find it even in hospital cohorts. That was a bit surprising to us. We thought perhaps that those who had sort of not signed up for this originally may have lower willingness rates, or those who may be younger and may have young families might be less willing for that reason. We really did not see that, and that was one of the counterintuitive results from our study.
Okay, there's a question in the back.
Yes. I would like to know, has there been any studies or research targeting community resilience in populations that have a mistrust in federal government, public health infrastructure, or the local government?
Yes, all the studies I've conducted, and I've done at least 3, looking at preparedness behavior perceptions among low-income and particularly African-American. And one of my students is about to do his dissertation where we did a study with the Hispanic population in Baltimore. And all of those studies, and in fact, trust is one of the constructs he's looking at in his dissertation. All the studies clearly indicate that that distrust is a major issue in terms of what to expect from public health and from other public sector. People are more trusting, for example, in our studies, of community-based organizations than they are of government, and that's a very important factor in terms of how do you increase trust levels or enhance trust levels between public and private sector, particularly at a time when there seems to be so much distrust in government right now. So how do we overcome that barrier is a question to be pursued.
Okay, we've run out of online questions. I think we should stop because I hear a class roaring to come in to our auditorium. But I want to thank both Dr. Barnett and Dr. Rowel for a really, really interesting presentation that leaves us with lots to think about, which is always how we like to end grand rounds. So thank you, everyone, for participating. And I hope you'll tune in November 20th. We'll be announcing the topic soon. And also remember that our grand rounds are the 3rd Wednesday of every month from noon to 1:30. So please put that on your calendars. Thank you very much.
Thank you. Always a pleasure, man. Always a pleasure.